Hey guys, Marshall with PhysioU. I'm here with Chris and Cam, two DPT students. And here at the teaching table where we bring the classroom to the clinic, we're going to talk about home exercise program. So the slogan is make it personal, make it specific. So what do I mean by that? We say make it personal, right? You may have 4 patients, all with stiff hip flexors. Doesn't necessarily mean they all need the exact same stretch. Make it match that person. Their lifestyle, their age, their demographics, whatever it may be. Another thing is make it specific, meaning how can you make it match the impairment that you found versus a general like shotgun approach per se. Right? So if we kind of move on, the idea is if I'm picking an exercise to have someone work on, at some point in my objective exam, I've proven that that's a problem. So either A, it matches an impairment I found. So if I'm giving someone a hamstring stretch, I've measured that that hamstring is stiffer than normal, stiffer than the other side, stiffer than what evidence says should be normal. Right? B, it's related to the patient's goals. So if we're working on, I'm having to do a running protocol on the treadmill, one of our goals should be getting back to running. Right? Lastly, it could match the diagnosis. So maybe the treatment we're working on is the evidence says, hey, if you have ankle sprains, you should work on proprioception and stability training. So somewhere I said, hey, the treatment I'm picking either matches the impairment that I found, matches what they're trying to get back to goals, or it matches the diagnosis that we found. Right? So it should always be somehow you should match. And you've measured it, you've tested it. The other thing about home exercise program is always the compliance issue, right? It's always kind of an issue. How do we help them improve compliance? And before I think we dive too much into that, let's take some questions that you guys had from the clinic where there were some difficulties or challenges with patients and their HEPs.
Yeah, so you talked about making it personal. I felt like I had this one patient, she was a heavier set patient. I was giving her some glute strengthening, and then I was giving her supine bridges on the floor. And every time she came back, I didn't do them. Came back to sighting visit, still haven't done them. So we just kept redoing the supine bridges on the table, and I just didn't know why she was doing it. I don't know if it was the exercise. I don't know, what do you find I could have done to help this patient?
So very common, right? Nice thing is at least she was honest and she said she didn't do them, right? Because if she's like, oh yeah, I did them all the time, then we start to think, okay, great. Hey, if it's not getting any better, then I must have picked the wrong exercise. Right? As it may turn out, you may have picked the wrong exercise just because she wasn't doing it. So we have to figure it out. So I think the fact that she's honest is good. The next step would be to know, well, what are some of the challenges you've had with the exercise? Right? I don't want to just assume it's, oh, you're being lazy and you're not doing them. Or maybe I'm assuming, oh, you're just forgetting to do them. Oh, you got to set a reminder on your clock, or you got to write yourself a little sticky note. Right? We don't necessarily want to go down that route unless that's the issue. So I would be like, hey, so this is our second visit in a row where you haven't performed a home exercise program. What are some of the issues that you're having with performing it? A little bit different than why aren't you doing it, right? Because you don't want to come off with a conflict. It's like, yeah, I'm going to call you out, but I'll call you out in a very nice way about it. So what are some of the issues you have doing there? Or can you help me understand? Can you help me understand why you haven't been able to do these? Maybe I can help we can find a way together. Right? And so you mentioned for her, she wasn't doing, maybe her answer was, it's really difficult for me to get on the floor. Okay, well, let's make a compromise. Can you do those exercises in the bed? Instead of me telling her, I'll ask her, can you do the exercises in bed versus, oh, do them in your bed then. Right? So if you get their approval and them saying yes, they can, right, that kind of helps solve the problem. I can think of many stories with either interns or even me earlier on where patients where I think this is the best way to do that impairment. So hip flexor stretch, right? Hey, get on the floor, get in that kneel, maybe get your foot up on a chair even, right? You can get a really good stretch in there, right? My 95-year-old lady that can't get off the floor isn't going to do that. But if I'm telling her to get on the floor, you got to realize, like, oh, what's most appropriate for you? Like, she may not even be able to lay on her back and let her leg hang off the edge like a Thomas test. Maybe it's really she just goes near a wall and just puts one leg behind her, and that's very appropriate for her, and she can get a stretch as long as she feels it, versus trying to find the most aggressive, right? So it's tailoring it to their age, tailoring it to what they're able to do, and most importantly, getting an understanding of what they're willing to do. You have a question?
Yeah, so I think being in the clinic, it's easy to get into the routine of giving that patient the TheraBand and saying okay, I want you to do this 3 times 10 repetitions, and then you just kind of keep that. Maybe you increase the TheraBand. Next time they come back, and the next time you come back, you increase it another one, and but it's still three sets of 10.
Right, 3 times 10.
Yeah, the classic, right? What do you recommend, students kind of taking more of a systematic approach to loading that patient or using that different sets and rep schemes?
I think that's a good question, and you see that across the board, and I'm totally guilty of falling into it as well. I think the idea is, can we first identify what category the patient's in? Right? So if this patient is in a coordination category, where we're not really doing this to make you stronger, we're not doing this to improve flexibility, it's like just for purely coordination of movement, right? The research says it should be high reps, right? These studies they're doing it 300 to 400 times a day with stroke patients. Yeah. So it's like, so I'll tell them, all right, I need 3 sets of 30, 3 times a day. Okay? That sounds like a lot when you say it to a patient, 90 reps, but I'll put it in time frames, right? I'll be like, hey, how much time can you spend on this in the morning? Oh, 5 minutes. Great, right? But you could do way more than 90 reps in 5 minutes, right? So it doesn't sound as scary. So okay, 5 minutes, 3 times a day. That's not bad, 15 minutes, right? We take showers longer than that sometimes. Not here in California, but right? But the idea is if you sell that first, and then you say, so to give you a number to work on, count to 30, and let's do 3 sets of 30. Make them do it in the clinic. Time them, right? Kind of prove to them that it's not as scary, right? That's why be coordination. Let's say we're working on flexibility. Right? There's evidence that suggests you need 20 seconds, 25 seconds to improve flexibility. So that becomes my new thing. However, I'm not going to do it 3 times. It's going to be, hey, can you spend 5 minutes on it? All right, 10 sets of 20 seconds, 10 sets of 30 seconds, right? Put it all in a group because we're trying to change that impairment, right? Yeah. The 3 sets of 10 really comes from like strengthening. That's kind of where it started. Like, hey, we want to work on strengthening. But even then, we can decide, is it endurance where we want higher reps, maybe lower weight? And again, the nice thing about all this stuff, there's a lot of evidence out there where you can look up, right, what percentage of 1 rep max should I be using for my endurance athletes? How many sets and reps? For power, how many sets and reps? Oh, I got to wait a lot longer. Plyometrics, right, hypertrophy. So based on what your goal is for that patient, then the dosage becomes a lot easier. Yeah. I think the hard thing is just realizing, well, what do I just need to get them stronger? Or is actually that muscle really small and tiny? So I'm going to work more on hypertrophy, or now we're working on agility and speed. We'll change your dosage. So as long as you kind of understand those, which the best is fine, is like go look up some articles about each category. I think one other tidbit I do is also I'll make them do it to fatigue. So if I'm in there and I'm saying, hey, we're going to do 3 sets of bridges, let's say 3 sets of 10 bridges, I'm going to make them do 10 bridges. And if all of a sudden they keep going, I'm like, well, let's just go to see how many you can do. What's your max? And they're getting to 42, 43, 44. All right, I got to figure out, I got to add more weight, or I'm going to be telling them you got to be doing 3 sets of 44. Yeah. Right? I'll often in the clinic find it for each patient. And I like it because it kind of fits into the specific, right? It makes it specific because you may have been able to do 42 bridges. Chris has really strong glutes and he can do 97 bridges, right? You guys are each going to have you'll have a different weight on your stomach, or you'll be doing 1 leg versus 2 legs. So it's make it specific that way. That's a good question.
I had another question regarding, say the patient comes back with HEP and they did not change. So in ortho, we learned this thing called the HOIC model, where you're seeing, did I implement the treatment correctly? Did I give them the right treatment? And is this person flexibility and I'm giving them a mobility type HEP? Or am I even, you mentioned goal, am I relating it to their goal? So what do I do in that scenario?
Okay, so patient comes in, they're no better. First thing I want to know, right, is did the impairment they were working on even change, right? If I went through an exam and I came to the conclusion that we're going to stretch hip flexors, right? That's our thing, right? I got to the conclusion, hey, you need to stretch your hip flexors. That was what I came to. The next time they come in, if they're no better, I want to know if the hip flexors are better, right? Because if the hip flexors are no better, then I'm not going to change from, oh, it's not a hip flexor problem, right? Hey, it's still impaired. I obviously thought this was the biggest one last time. It's still impaired. So I'm going to now have to decide, is the exercise I gave her, is that exercise not the best for a hip flexor stretch? So I'm only going back one level, right? Just going back to sticking with hip flexor stretch, maybe the way that the patient was doing it, right, is wrong. And like we've talked in the other ones, right, what they show you is not necessarily what you showed them the day they left. So hey, you know what, let's go over that exercise. You show me what you were doing. That way you can see what they do versus you set them up, right? Let them see. And let's say for this example, she does it great. It's perfect. She feels it in the hip flexor stretch. She feels it in the hip flexor. She's stretching it right. And you're like, okay, so she's doing it correctly. I still think that's the number one impairment because it didn't change. So then what should I do differently, right? Well, either A, I'm going to make her do that exercise a lot more, right? I'll say, hey, you're feeling it right where you should feel it. You were doing it for 3 minutes, twice a day. It didn't change. What can we do differently, right? Can I change the intensity of the stretch? Hey, you know what? I need you to make the stretch a little deeper. Put an ankle weight on your leg when you hang off the edge of the table, right? Or B, maybe it's a timeline. Hey, you're holding it for 20 seconds. Any way you can hold that for a minute, right? Instead of doing it twice a day, any way you can do it for 4 minutes, right? Or 4 times a day. Like, I'll stick with the same intervention, just a lot. I'll change the dosage to make it match because it didn't change. Now, let's say she's no better. You go in, you measure Thomas test, and all of a sudden she's gained 15 degrees of range. God, it's actually better than the other side now, right? Should I keep stretching that hip flexor? No. So that's where I might have to take 2 steps back, right? But before I took my second step back, I checked my first step. Is the impairment better? The impairment's better. Your pain's not better. Okay, I'm going to jump ship now and move to something else. Versus the first scenario, I'm not going to jump ship. Stay with what you thought, ride it out until you make a change. And then we can move back and say, hey, maybe I need to look at another impairment. Yeah, that's a good question. I feel like sometimes as therapists, and especially early therapists, young therapists, every time the patient comes in, you have to change to something new, change to something new. Now by visit 4, you've done 4 different things. Patient has 8, 9, 10 exercises at home they're working on, and you're not quite sure. So it's like, hey, if you're mobility, stick with mobility. If it's lumbar extension mobility you're working on, stay with lumbar extension mobility. And you may give them a different exercise, but it should still match lumbar extension mobility. It's just maybe you progressed it, or maybe you put them in a different position, or maybe you gave them an exercise that they don't have to lay down to do at home. Now they can do this lumbar extension mobility all the time throughout the day. So it's another exercise. They think they're progressing, but you, the smart clinician, is like, hey, my clinical reasoning, I'm still sticking with this one impairment, this one category.
Got it.
Those are good. Yeah, so I think we talked about dosage. We talked about making it match. Some of the things that I want to bring up is patients after they leave physical therapy, they've done studies, 70% of them don't remember what their exercises were. But they do remember, a high percentage remember what the modifications you made were. So for your runner girl whose knee dove in, I think in a different one we talked about, a lot of valgus stress, teaching her that her knee to not dive in when she goes upstairs, when she does a squat. She won't remember the clamshells on her side, but she'll remember, oh, keep my knee out, keep my knee in alignment. Right? Don't just treat the impairment. So we're giving this person a lot of lumbar extension stuff, right? Treat the function. Hey, when you're sitting, try not to sit in flexion all the time, right? Try not to sit on your computer in your bed. Like, hey, treat the things that bother them. You hurt them sitting, let's have you sit in a better position. And I'll tell people, that's your therapy. You're doing therapy right now by having a better spine alignment. Right? You're loading your joints differently. You're using your muscles differently just by sitting like this. Right? And then remember, right, the best HEP is the one that gets done. So if the patients aren't willing to do it, don't blame them and say, why aren't you doing it? Make it a your problem. How can I help you? How can I help you get this done? What are some of the obstacles you have to doing it? We don't make 95-year-old ladies get on the floor if they can't get off the floor, right? Make it personal. Good. Yeah, so that does it for our with our teaching table with PhysioU. Take a look at PhysioU.com. We have a great app called the Clinical Pattern Recognition that kind of has home exercise programs for the whole body and stuff. Follow us on social media. Thanks, guys. Take care.